Here's something that will stop you cold. A person walks into a medical building feeling completely fine. No pain, no symptoms, no reason for concern. They walk out with a diagnosis that changes the entire trajectory of their life, not because something was wrong with them, but because a routine test found something that medicine felt compelled to act on. And here's the part that should make you sit up straight. In many of those cases, the research suggests, village research indicates, that a more conservative, watchful approach, rather than immediate aggressive intervention, would have led to an equally good or better outcome. We're not talking about rare edge cases. We're talking about a pattern documented across major peer-reviewed journals, studied by the very agencies that set national screening guidelines, and almost never discussed openly in the 15 minutes you get with your doctor once a year. Today we're going to change that. This channel, Golden Glow Senior, exists for one reason: to give you the kind of honest, evidence-rooted information that helps you protect your health and your quality of life after 60. And what we're covering today may be the most important conversation on this channel yet. We're going through 5 routine medical checkups that the research says deserve serious reconsideration after the age of 70. Not because medicine is broken, medicine has made extraordinary advances, but because the risk-benefit equation shifts with age, and that conversation doesn't always happen fully in the exam room. Stay with me through all 5, because what I share at the 7-minute mark is something most people never hear until it's already too late. Before we get into the 5 checkups, I need to give you one concept, because without it, nothing that follows will fully land. Think of it as the longevity lens. At 50, screening medicine works beautifully. You find a problem early, treat it, and potentially gain decades of healthy life. The investment makes sense, the math is clean. But after 70, 3 things change that math significantly. First, modern medicine increasingly recognizes a principle called active surveillance. And it's one of the most important shifts in clinical thinking in recent decades. Not every finding needs immediate treatment. Many conditions, once detected, can be monitored carefully over time. If they grow or change, treatment begins. If they remain stable and cause no symptoms, the patient avoids unnecessary intervention. This approach is now standard of care for many slow-growing cancers and other conditions. Second, your body's tolerance for medical intervention changes with age. A procedure that a 55-year-old recovers from in 2 weeks can mean a longer, more complex recovery for someone at 78. This doesn't mean procedures should be avoided. It means the risk-benefit calculation must be more precise. Third, and this is the one that most people never see coming, there is the cascade effect. One test finds a small abnormality. That triggers a follow-up scan. The scan suggests a biopsy. The biopsy leads to a procedure. The procedure carries complications. And a person who walked in feeling well is now navigating a medical situation they never anticipated, all set in motion by a test that, in retrospect, may not have changed their outcome. This is the lens through which I want you to hear everything that follows. And I want to be absolutely clear, this is not about avoiding medicine. Modern medicine saves lives every day, and we will acknowledge that throughout this video. This is about being an informed participant in your own care, which is exactly what you're becoming right now. Keep that framework in mind, because checkup number 1 involves something almost universally considered responsible preventive care: routine colonoscopy. Almost everyone over a certain age has had one, has been told they need one, or knows someone who went through one without a second thought. Here's what the evidence actually says. The United States Preventive Services Task Force, the gold standard body that sets national screening guidelines, officially recommends against routine colonoscopy screening for average-risk adults over the age of 75. Their analysis is clear. After 75, for people with no symptoms, no family history, and clean previous scopes, the benefits of routine screening diminish, while certain risks deserve careful consideration. Now, colonoscopy is generally a very safe procedure, and serious complications are uncommon, but they are not zero. Bowel perforation, a tear in the colon wall, is a rare but recognized complication, occurring in roughly 1 in 500 colonoscopies. In a younger adult, this is typically a manageable surgical complication. In an older adult, particularly one with other health conditions, the recovery can be more involved. There is also the bowel preparation itself, the cleansing process required before the procedure. This involves significant fluid shifts that can affect kidney function and electrolyte balance. For patients who already have some degree of reduced kidney function, which is not uncommon after 70, this aspect of the process deserves attention and should be discussed with your physician in advance. Meanwhile, the colon cancers most likely to be detected in asymptomatic older adults during routine screening tend to grow slowly enough that in some cases they may never become clinically significant within a person's natural lifespan. The practical alternative: ask your doctor about a non-invasive stool-based test. Options like the annual FIT test can identify genuine warning signs without procedural risk. If you do have symptoms, blood in your stool, unexplained changes in bowel habits, abdominal pain, that changes the equation entirely. Get evaluated promptly. If you do have symptoms, blood in your stool, unexplained changes in bowel habits, abdominal pain, that changes the equation entirely. Get evaluated promptly. The recommendation against routine screening absolutely does not apply to symptomatic patients. Now, Checkup 2 involves cancer screening. And what we're about to say requires nuance, because this isn't about avoiding cancer detection. It's about understanding the concept of overdiagnosis, and why that story is more complicated than most people realize. Let me be precise, because this topic deserves care. Cancer screening has saved millions of lives. It can save yours. What the research points to, specifically in average-risk, asymptomatic, older individuals, is a well-documented problem called overdiagnosis. An overdiagnosis, when not properly managed, can lead to overtreatment. Here's what overdiagnosis means in plain language. Imaging technology today is so sensitive that it can detect cancers that are, biologically speaking, barely awake. Tiny, slow-growing findings that, if managed appropriately with active surveillance, would never cause a symptom or shorten a person's life. And this is where modern medicine has made a genuinely important advance. Not every cancer diagnosis automatically leads to surgery or aggressive treatment anymore. Active surveillance is now a recognized, guideline-supported management strategy for many low-grade, slow-growing cancers, particularly certain prostate cancers, some thyroid cancers, and other indolent findings. That said, and this is critical, not all cancers are suitable for surveillance. Some prostate cancers are aggressive and require prompt treatment. Some findings in older adults represent real, immediate threats. The determination of which category a finding falls into depends on tumor grade, imaging characteristics, biopsy results, and the patient's overall health. This is a conversation that belongs between you and a specialist. Not a decision to be made based on fear alone or dismissed without evaluation. The practical approach: if something is found, ask your doctor directly. What is the grade and growth rate of this finding? Is active surveillance appropriate in my case? What are the criteria for moving from monitoring to treatment? These questions move the conversation toward individualized, evidence-based care. This brings me to something I want to pause on before we go further, because the next checkup is one that surprises almost everyone. What we've been walking through, the colonoscopy guidelines, the overdiagnosis problem, the active surveillance revolution, this is the kind of information that almost never makes it into a standard appointment. It doesn't fit into 15 minutes, and it rarely surfaces in general health articles, because connecting these dots requires reading across multiple fields of research simultaneously. That's what this channel does every single week. If you're not subscribed to Golden Glow Senior yet, I'd encourage you to do that right now. Hit subscribe and turn on notifications, because every week we bring you this kind of honest, evidence-based conversation about what the research actually says about your health after 60. Not trends, not alarm, just the information you need to make genuinely informed decisions. Subscribe and let's keep going, because Checkup 3 is the one that stops most people cold. Cardiac stress tests. This one surprises people because the logic sounds so reasonable. You're 72, your doctor says. Let's just make sure your heart is doing okay. You get on a treadmill, or you receive a medication that temporarily stresses your heart while they monitor the response. Sounds responsible. Here's what the data shows, and it requires some important context. Cardiac stress tests in people without symptoms can have false positive rates that are meaningfully elevated in certain populations. When a stress test suggests an abnormality, the next step is often cardiac catheterization, a procedure that threads a thin tube through your blood vessels into your heart to get a direct look. When performed by experienced teams, serious complications are uncommon. But like all invasive procedures, it is not risk-free. Here's where I want to be accurate with you. Cardiac catheterization today is a well-established, generally safe procedure. When performed by experienced teams, serious complications are uncommon. But like all invasive procedures, it is not risk-free. There are small but real risks of bleeding, vessel injury, and in rare cases, arrhythmia, which is quite common in adults over 70. What happens next depends enormously on the clinical picture. This is where the research becomes genuinely important. Coronary stents are not one-size-fits-all. Multiple landmark clinical trials have shown that in patients with stable coronary artery disease, blockages that are not actively causing a heart attack, stenting did not reduce heart attacks or extend life compared to optimal medical therapy alone. However, and this is critical, in the setting of an acute heart attack, stenting can be life-saving. The data here is unambiguous. When a coronary artery is acutely blocked and a patient is having a heart attack, rapid intervention with a stent can save the heart muscle and save the life. So the question isn't, are stents good or bad? The question is, what is the clinical indication? A stent placed for an acute MI is a different intervention entirely from a stent placed for a stable, incidentally found blockage in an asymptomatic patient. The practical approach, if you have no chest pain, no unexplained shortness of breath, no exertional symptoms, talk to your doctor about optimizing modifiable risk factors. Blood pressure, cholesterol, blood sugar, activity level. That's where the strongest preventive evidence lies for stable patients. And as always, if you develop symptoms, seek evaluation promptly. Symptoms change the entire equation. Osteoporosis is real. Falls are genuinely devastating in older adults. Hip fractures in particular carry serious consequences for independence and survival. So I want to be careful here, because what I'm questioning is not the importance of bone health. I'm questioning the automatic clinical pipeline that sometimes follows a bone density scan. A DEXA scan detects low bone density. A medication is prescribed, often a bisphosphonate. Years of treatment follow. Here's what should be part of that conversation. Bisphosphonates are effective medications with a real evidence base for reducing fracture risk in the right patients. For individuals who have already experienced a fragility fracture or who have very low bone density scores, the benefit is well established and the medication is genuinely warranted. The key principle, expected benefit, must always be weighed against known risks. One is atypical femoral fractures, stress fractures in the thigh bone that, paradoxically, can occur with extended use of the medication meant to protect bone. These are rare, but they are real, and they are in the prescribing literature. Another is osteonecrosis of the jaw, a condition affecting jawbone tissue that is associated with bisphosphonate use, particularly in higher dose contexts. The key principle, expected benefit must always be weighed against known risks. For high-risk patients, the fracture prevention benefit typically outweighs these concerns. For lower-risk patients, those with modestly reduced bone density and no fracture history, that calculation deserves a genuine, individualized conversation. And here's what the evidence strongly supports, regardless of medication status. Fall prevention works. Balance training, Tai Chi specifically, has been shown in multiple studies to reduce fall risk substantially. Combined with removing household hazards, reviewing medications that cause dizziness, maintaining vision correction, ensuring adequate protein and vitamin D, and appropriate exercise. Ensuring adequate protein and vitamin D and appropriate exercise to give them what you now have, the right questions, the right framework, and the confidence to be an active participant in their own care. These interventions reduce real-world fracture risk in ways that are measurable, meaningful, and carry zero pharmaceutical side effects. Before starting any long-term bone medication, ask, what is my specific fracture risk? And how does the expected benefit from this medication compare to the risks for someone with my profile? Now, we've arrived at Checkup 5, and I promised you the strongest, most surprising insight in this video lands right here. This is the one almost nobody is talking about openly: carotid artery screening. You've probably never been warned about this one. Most people haven't. Here's the idea behind it. The carotid arteries are the large blood vessels in your neck that carry blood to your brain. If we find a significant blockage, we can potentially treat it and reduce stroke risk. The logic sounds sensible. Here's where precision matters. The screening itself, a carotid ultrasound, is completely safe. It's a painless, non-invasive imaging test. The ultrasound carries no risk whatsoever. The issue lies in what can happen after the finding. The United States Preventive Services Task Force recommends against routine carotid artery screening in adults who have no symptoms, no mini-strokes, no sudden vision changes, no neurological episodes. Their analysis found that in asymptomatic individuals, the risk of harm from the surgical intervention that screening can lead to. Here is the mechanism that makes this so important to understand. Many people over 70 have some degree of narrowing in their carotid arteries. Stable narrowing that has been present for years, causing no problems. That surgery carries a recognized risk, approximately 2 to 3% risk of causing a stroke during or shortly after the procedure itself. In older adults with additional health conditions, that risk can be higher. So the paradox is this: the procedure designed to prevent a stroke in an asymptomatic patient carries a meaningful risk of causing one. When the person had no symptoms to begin with, that balance is difficult to justify. Now, for patients who have had symptoms, the calculation is very different. If you've experienced a transient ischemic attack, sudden vision loss, or any neurological episode, carotid evaluation is entirely appropriate and intervention may well be indicated. As always, the principle holds: every procedure must be evaluated through the lens of expected benefit versus known risk. For this specific patient, at this specific time, the most powerful stroke prevention for asymptomatic individuals remains aggressive blood pressure management, blood sugar control, treatment of atrial fibrillation if present, smoking cessation, and regular physical activity. The 5-question protocol. Here is something practical you can use at your very next appointment. Before agreeing to any routine screening test, especially after 70, have these 5 questions ready. Question 1. What is the false positive rate of this test in people my age? This tells you how likely the test is to trigger unnecessary follow-up procedures even when nothing is actually wrong. Question 2. If this test finds something, what are the realistic management options, including active surveillance, for someone my age and health status? This moves the conversation toward outcomes and options, not just findings. Question 3. What is the procedural risk of any intervention we'd likely pursue? Every procedure carries risk. You deserve to know the numbers before you agree to the test that might lead there. Question 4. What happens if we monitor this carefully rather than treating it immediately? For many conditions found in older adults, watchful waiting with clear criteria for intervention is a legitimate and sometimes superior clinical strategy. Question 5. What is the expected benefit of this intervention for my specific risk profile? And how does the expected benefit from this medication compare to the risks for someone with my profile? And how does it compare to the known risks? Because as we've seen today, The benefit-risk equation is always individualized, and you deserve to understand where you stand on that scale. Any good physician will welcome these questions, and if a doctor dismisses them or makes you feel difficult for asking, that's important information about whether that physician is the right fit for you. Before the final thought, I want to say something directly. What we covered today, the cascade effect, the overdiagnosis problem, the nuances of stenting, the carotid screening paradox, this is not information that's easy to find in one place. Bringing that research to you in plain and accurate language every week, that's what Golden Glow Senior is built to do. If you haven't subscribed yet, please do it right now. One tap, and turn on notifications so you don't miss what's coming next. And if you know someone over 70 who is navigating medical decisions right now, share this video with them, not to create fear, to give them what you now have, the right questions, the right framework, and the confidence to be an active participant in their own care. There's a difference between medicine that finds things and medicine that helps you live well. After 70, the goal of your healthcare shouldn't be to generate findings for their own sake. It should be to protect your independence, your energy, and your ability to do what matters to you, for as long as possible. The best medical thinking today keeps returning to one core principle. Every intervention must be weighed honestly against its expected benefit and its known risks. Modern medicine, at its best, embraces this complexity. It offers active surveillance as a legitimate path. It distinguishes between a heart attack requiring emergency intervention and stable disease requiring thoughtful management. The best medical thinking today keeps returning to one core principle. Every intervention must be weighed honestly against its expected benefit and its known risks. For this patient, in this moment, that principle applies to a colonoscopy prep in a patient with kidney disease. It applies to a stent in stable coronary artery disease. It applies to bisphosphonate therapy after a bone scan. You have the right to be part of that conversation. You've always had it. Today, you're leaving with something concrete, a framework, 5 questions. It distinguishes between a heart attack requiring emergency intervention and stable disease requiring thoughtful management. It weighs the fracture prevention benefit of medication against its long-term risks, and a clearer picture of how the risk-benefit equation shifts with age. Use it at your next appointment. Share it with someone who needs it. That's what this community is here for. Leave a comment below. Has a routine test ever led you somewhere unexpected? Your experience could be exactly what someone else needs to hear before their next appointment. Take care of yourselves. We'll see you in the next one. Take care of yourselves. We'll see you in the next one.